right, we are live. Welcome everyone to our August Journal Club. Very exciting topic tonight on cervicogenic dizziness. And we have with us two very special guests. So we're very excited to have Dr. Harrison Vaughan and Dr. Danielle Vaughan. So I'm going to let them each sequentially introduce themselves with a little bit of background, and then we'll get right into the article. And for anyone who didn't receive the article yet, I promise it is going to be posted up very soon, and I'll also email anyone who was kind of a last-minute registrant after the fact. I just didn't get a chance to do that in those final minutes. You guys are really pushing it on the signing up, which is exciting. I know you're busy people, so we'll make sure you get that article, okay?
All right, yeah, I'll go ahead and introduce myself. First, I'd just like to say thank you for having us. We're a big fan of your products and your journal club and the culture that you've created, so it's really fun to be here. We're really excited to talk about cervicogenic dizziness. My husband and I have spent many years in studying this, and even though it's been a controversial topic in the past, it's really evolving. So it's been really neat to be in the forefront of that and to get the knowledge out there on what we are learning as we are learning about the diagnosis. So again, my name's Danielle. I'm a physical therapist, and I have a specialty in passion and vestibular rehab. And this is my husband, Harrison.
Yeah, so I'm Harrison Vaughan, physical therapist, and my passion and background is more in the orthopedic manual therapy world as a fellow. And so, yeah, I want to echo Danielle that we're really excited to bring this product and just talk about how we've almost integrated what we do within the vestibular and orthopedic field to sort of merge this topic, which is really where the evidence is going in the last few years, and not just from a orthopedic manual world, but kind of incorporating both of these concepts. So thanks for having us.
Oh, it's our pleasure. Great. So I'm going to go ahead and switch our slides right over to discussing the article. And in there, we'll kind of touch base with both Harrison and Danielle, ask them questions along the way from kind of my perspective looking at the slides. And then at the end, we'll have an opportunity for everyone who's interested to submit questions to the live chat, and we'll get answers as best we can from those as well. So here we go. We're going to start rolling right through the slides here. So this is the article, and again, anyone who didn't receive it, you can also email us at support@vestibularfirst.com if you don't find access to it any other way. And the first thing we want to, of course, do is define cervicogenic dizziness, which in and of itself, as mentioned, is a highly debated topic, including the definition, but I'll do my best here. And the way the article describes it is changes in upper cervical spine muscles and joint receptors due to any of the following or a combination thereof: poor posture, damage to the proprioceptors, usually from trauma, perhaps car accident, a kind of sports trauma, anything like that, abnormal range of motion, or changes in vertebrobasilar or artery blood flow. It's always a tough word for me. And all of that, or one of those things, could result in a mismatch in information between the vestibular nuclei, our vestibular system, if you will, as a whole, really, and this kind of cervical proprioceptive input, right? So if they're not in agreement, I always say to the patients, the brain is going to say, wait, where are we? Things are not on the same page here. I'm not getting the same information from my different sensory systems, and so I'm going to have some symptoms. So again, going back to kind of some folks' official definition, the patient is going to have a current complaint of dizziness, which, of course, we know the verbiage can vary. It may be described as more of a lightheadedness, although, we hopefully have ruled out kind of a syncopal issue, blood pressure changes, heart rate changes, that sort of thing. They might feel spacey. I've heard off a lot. Some folks might even say it feels like my head's not attached to my body, floaty, that kind of thing. In addition, they may report a sense of imbalance or unsteadiness, a sense of neck stiffness, even tinnitus, which is a many and varied symptom of many vestibular conditions as well. So not necessarily that helpful, but they might report that. They might report some jaw or kind of TMJ pain, and they might report psychological issues, whether it's anxiety, depression, of even kind of larger psychiatric conditions, which may or may not be related, but just good to kind of be aware. We know also that there must have some history of neck trauma or pathology. So that's pretty broad, right? That can include that poor posture, and perhaps some sort of vascular issue in the neck, things like that, and some sort of complaint of neck pain to consider the diagnosis. Now, I'll be interested to hear from our experts on that. Do you feel that neck pain is truly necessary for you to feel like the person has an element of cervicogenic dizziness?
So, for the most part, historically, neck pain has been kind of a definition, as you've mentioned, Elena. And so, way we conceptualize it is based off of a hierarchy of whatever threat is to the central nervous system. And so, for instance, majority of people have poor posture or some of these other conditions that have a history of neck pain or a broad term of cervical disorders or arthritis. But my main thought on this is that majority of people are going to have neck pain, but pain is a broad term, and that could just include stiffness or tightness. But I think if the symptoms are arising from the cervical spine, by the time those individuals are getting that signal, the nervous system is saying, I'm not even concerned about pain. I'm going to give you an off sensation, a lightheadedness, a drunkenness, a unsteadiness, because that is a higher threat to the hierarchy here. And it's just trying to tell the person, look, you got to do something. The neck pain is not a big enough signal at this point. So I would say, to answer your question, majority of the time they will, but don't let that just solely, I wouldn't exclude them totally if they say, I'm not really feeling any pain right now.
That's fair enough. And I think that speaks to a broader issue. You know, we have patients with vestibular issues. I think Danielle can attest to this as well. 2 patients come in, same condition, BPPV, little crystals out of place in our inner ear. When I do a test, that would provoke that, one patient says, whoa, I'm spinning, I feel so much symptom. And the next person says, I feel a little funny and off. But their eyes, which are, my main indicator for whether the crystals are out of place, if they're doing very characteristic movements that follow a really specific, predictable pattern, are doing the same thing in both folks. And I think that kind of just pins down what you're saying, is that unfortunately, even though we lean on patient report, for our diagnosis of various conditions, it can be really challenging by itself to be the way to know, yep, it's this and not that. And that's what I'm hearing from you, is that if the person doesn't strongly say, oh, my neck's a little tight, a little sore, that's not their main complaint, that doesn't mean it's not cervicogenic dizziness. Is that what I'm hearing?
Correct.
Cool.
Yes. All
right. Good deal. All right. So this leads us to our next slide. Cervicogenic dizziness is difficult and sometimes controversial to diagnosis because there's no single diagnostic test to confirm. I feel like doctors in particular really don't like when that's the case. I don't think anyone wants to find a tumor on a scan, but when a patient comes in with a bunch of complaints and they do a scan and there's a huge tumor, it's like, oh, well, that explains that, right? So we gotta have this pretty clear, yep, A plus B equals C type of thing here. Symptoms, test says this, okay, you've got this going on. But the human body is beautifully complex, and therefore, in many conditions, it's not always A plus B equals C as far as, a clear-cut test that tells us, yes, this is definitely it. So we have to really put on our thinking caps and see what pieces come together to make sense. Secondly, often considered a diagnosis of exclusion. So you do want to rule out what we'll call the more obvious kind of causes of dizziness. So, if you haven't looked for BPPV, as previously mentioned, being pretty much the most common cause of certainly positional vertigo for sure, that kind of symptom where I feel it when I move, that's, want to definitely check for BPPV, right? We don't want to skip that step. And then, of course, medical causes of dizziness, right? If a person is just really low hemoglobin. Let's hit that first before we jump to the neck, right? And I know that we're all kind of trying to operate with collaboration, with maybe other healthcare providers to make sure that communication is happening to say, hey, by the way, has this been checked? Because the patient may or not be sure what's been checked or what have you. So we might have to touch back. And of course, to make it all more complicated, cervicogenic dizziness can coexist with other causes of dizziness. And I certainly can say I've seen this. And a great example would be someone comes in, I find BPPV, I treat that. They're definitely feeling better, but they still feel off. I'm finding some neck findings, which we'll talk about, what some of those might look like. We treat the neck a bit, and then they feel, closer to 100%. So, I got my little graphic here, which came first, the dizziness or the neck pain. It's certainly complicated because when someone comes in with BPV, they've been walking around like this. I call it the Frankenstein mode, right? That can contribute to some neck issue as well, which maybe could contribute to some symptoms. So all circling back. So this is a beautiful figure that was included in the study, the article that we're discussing. Just trying to kind of break down why you want to kind of go through somewhat of a sequential, but maybe in parallel assessment of vestibular system, your central nervous system, looking, cranial nerves, things like that, cardiovascular system, and then, musculoskeletal system, and then kind of coming into more of this kind of neck specific assessment and looking at different pieces, which we're going to talk about shortly. So this is the assessment portion of the article. So I made an order that made sense to me. I don't know if this is exactly the order that was in the article. And we did add one thing else to discuss, which was cervical distraction. So let's start with our dizziness handicap inventory, which any vestibular therapist is most likely familiar with. This is a 25-question kind of patient report type assessment. And what they described in the article is that there are 3 questions that specifically are most likely to be answered positively or with a yes if cervicogenic dizziness ends up being the diagnosis. So it doesn't mean if they answer yes that it's definitely cervicogenic dizziness, just to be clear, but it does mean that if this kind of gets 3 yeses on these questions and we find some other tests that are kind of leaning us towards cervicogenic dizziness, that's a more kind of a stronger argument for cervicogenic dizziness, we'll say. And the other thing they found is that for question 9, which is asking about, are you afraid to leave home without someone accompanying you because of your problem? If they answer no, that again was more strongly correlated with folks who had cervicogenic dizziness versus those with what they call general dizziness in that particular study they were quoting. So just kind of something to take a look at. Most vestibular therapists, I think, are giving this on intake, so it's kind of an easy thing. I maybe do it in advance even of them coming into the clinic if you're lucky. So, that's something you can use as a piece of your puzzle. Now we're going to talk about ligamentous testing, which the article spent some time describing and encouraging. And this to me is primarily a safety issue, and I think any orthopedist worth their salt would say, of course, you take 2 seconds and check these and move on. But it's good to just kind of go through that briefly. So the sharp purser test, which you can do a few different ways, but they describe seated for the transverse ligament. Hopefully, again, any physical therapist and any manual therapist of any kind might be familiar with this test. And to me, basically, it's one of those, if positive, do not pass go. Please refer. And, we're concerned about cervical instability that's not been addressed, whether that means they need some sort of surgical intervention or just some sort of stabilization with a collar, or maybe the doctor says, nope, go ahead and move on. We'll see. But, at the end of the day, if no one else is kind of know about this already and we're the first ones to find it, we want to send out. At least that's my 2 cents on that. Do you agree with that?
Yeah, absolutely. I mean, if you are any concern, or especially if this test is positive or the modified sharp purser, that would be an absolute contraindication to continue. It doesn't matter if you want to massage them or immobilize them. You move on. Yeah.
Right. So that's why I put this first, because then I don't have to do the other tests. If this comes out positive, I'm moving on. Writing my note. All right. Similarly, the ALR ligament stress test, would you approach that the same way?
Yeah. The alar ligament, this is kind of part of our algorithm as well. We have a few of these ligamentous tests, and we actually have some pretty decent studies looking at this through 3 different methodologies now, through the Harry study, like 2 or 3 years ago. But yeah, same concept. If it's something that you are concerned and it matches up with the history, yeah, it's a contraindication. Just go and just refer on to the appropriate practitioner, and that way, when you treat them, you're much more positive that this is what is needed for this individual and not going to do any harm.
Got it. And just because I had a patient today for my evaluation that has Ehlers-Danlos, are there these ever positive on those folks just because they're so loose everywhere, or is that not likely?
Yeah, good question. So the main concept with these tests, are you looking at instability or hypermobility? All right, so hypermobility doesn't mean instability. And so the likelihood of these being positive or meaningful are low. Okay, it's a lower likelihood that's the case. But if the mechanism of injury or trauma or medical history matches up, you would. So to answer your question, some of these people might have hypermobility, but it doesn't equate to instability. So if there's no recent trauma or anything of that nature, and nothing else matches up, lump in the throat, metallic taste in the tongue, that type of thing, I would say that as part of their history. It doesn't mean be too standoffish. You may not want to go in for high velocity techniques or anything, but there are lots of other ways to strategize to change the afferent input from the proprioceptors, muscle spindles.
Perfect. Yes, I concur. You don't necessarily go heavy on the manual with those Ehlers-Danlos folks anyway, in my opinion. So
Yeah.
let's strengthen and stabilize. All right. So moving on to excellent test to look at deep neck flexor neuromuscular control. So strength to me is not kind of complete to say just that. So they describe this test in a very particular way, and using your pressure biofeedback unit, and getting some numbers, and then being able to use that to look at, are they able to activate, and are they able to have endurance to these. Now, I also have to admit that in school, many moons ago, I learned a very simple way where you simply have them pick up against gravity, hold tucked, see how many seconds they hold before they seem to kind of lose it. How would you compare those? Do you think that this is a better test, or does someone always have to have this equipment? What do you think?
So yeah, I'll answer that one. So this is
Sorry,
more my
Danielle.
jam. So I agree with you, Helena. I'm definitely more into the craniocervical flexion endurance test, which is the lifting the head. And for the most part, the amount of time varies through the literature on how long you can, or is someone supposed to hold it. For the most part, if you look at the Olsen 2006 study, it's 20 seconds for females, 25 seconds for men. But it can vary. It can even go up to 40 seconds, and that's like the neck. You can sort of combine this test with the neck steadiness test and just see how much shape the person has when they lift up. And there's like almost a combined, and that's rated at 40 seconds. So what we do is I kind of do that test myself, because this, quite frankly, in the clinic, this is great. It's more scrutinized in the literature through Deborah Fowler's work, and it goes back in history and studied more. And it's it has some validity through the EMG, through the nasopharyngeal port, all the way to the longus colli, where we don't have that with the neck endurance test. But we look and see if things are activated where they should, if it is going to be feeling it here, or if they feel it in the posterior cervical muscles, or if that gives them a symptom of what they might have, or create a headache, or if they can't hold it, of course, and if criteria for that one test. So to answer your question, I think we typically go with the other one because it's a little quicker through the initial screening process, but then this could be utilized for some biofeedback training as you need it, where the other one doesn't have as much of that biofeedback training.
Right, good point. So we'll call it pros and cons, efficiency, and are we just trying to get a sense that the deep neck flexors need work, versus do we want some specific numbers for goals? And then related to that, are you going to be using something like this for training? Kind of may be more useful if you have access to it. Is that what I'm hearing?
Yeah. So we don't have it's. I utilize it for all the above. Yeah, we don't have a direct number. Someone say they hold it 15 seconds. It doesn't mean they have cervicogenic dizziness. Like if they can't hold beyond, we don't have any numbers like that for
Okay.
whiplash associated disorders. More than 23 millimeters of mercury has been shown for these guys, but that's just a clinical call, and it can create goals, absolutely. Or if they're getting any neurological symptoms with it, of course, you don't want that, which could be any of the above symptoms. So this is definitely used more in the research realm. I know from teaching all over, a lot of people do the other one because it's a little quicker too, just clinically based versus research based. Yeah.
Fair enough. So pros and cons, but we'll say that some sort of test to look at deep neck flexor activation, endurance, what you want to call it, just kind of see what's happening there. And if there appears to be a pretty clear issue of pain provoked, or, they just can't hold their head up and that kind of thing, we note that. And that's another piece of our puzzle. Very good. All right. Next, one of my personal favorites, the cervical joint position error test. Mostly because patients think it's cool. They're like, ooh, a laser. Now we know you're fancy. So the way I was taught to do this test by Rob Landell, because I several years ago took his cervicogenic course. So correct me if anything is updated from this, but you're going to put the laser on the head, something like what's shown in the picture. There's different versions. Basically, you want something that's not going to slip around and things like that. And you're going to have the patient set up in a very particular way. And actually, I believe it for sure. Rob Landell has it up for free still on his SkillWorks. And I have it listed here where you can get the target. On the second page of that document, it explains how to set it up, that they need to be 90 centimeters from the center of their head where their neck would rotate, and things like that. So you do need to set it up a particular way for it to be an accurate test, just to be clear. But once it's set up properly, the patient closes their eyes. You ask them to turn their head to a comfortable manner, say to the right, and then come back to what feels like center, have them open their eyes, see how they did, kind of thing, right? So we're looking at left, right, up and down, back to center. And if they're landing beyond the yellow circle, as you see kind of the colored circles there in the picture, and having people land completely off the paper and on repeat, right? So you're doing trials and a whole thing. It doesn't take too long, I think, usually in total to do properly, however, so that's nice about it. And you're just trying to see loosely if the neck knows where it is what I tell the patient. And that's testing their cervical proprioception. So I would ask Danielle here, because I have patients who have, vestibular issues, say concussion, what's kind of your instinct to pull this test out for kind of these mixed patients? I do pull it out from time to time for kind of not the typical cervicogenic dizziness presentation. What do you think?
Yeah, this test is typically something that I do on the second visit. I don't always get it in the first go around. I do think it's important, but it's one of those things that sometimes I just don't get to the second day. I mean, we've got so many other things to cover. But of course, the person that feels like they have that bobblehead sensation, of course, if you are suspecting anything VOR, you're doing adaptation exercises, that good old patient that has that head that like can't quite, stay on one plane of motion. That's always a big indicator where I normally will pull that out. As far as for cervicogenic dizziness, it's one of our most sensitive tests. And as you probably have experienced in what we even in our course, when we have everybody do it, I mean, a lot of people are positive with this, where they can't get it where it's supposed to be. So normally if you have somebody who's getting within that 4.5 degree, bullet or target that you're trying to get to, if they're pretty accurate in that, then you can feel pretty confident that maybe their proprioception is fairly good. So just kind of keeping that in mind. And they say to do about 6 trials, and so I normally go at least 3, and then if they're hitting it pretty spot on for 3 in all directions, then I just kind of move forward from there.
Yeah, for sure. Yeah, what I was told in Rob's course was look for consistency. So like if every time they're landing in a completely different spot, that's maybe less useful than if like I've done it where they've done like 4 trials in a row and they're just landing on this one like left hand corner. And I'm like, okay, that's a problem area here, you know. Figuring out what to do with that is something we'll talk about shortly, but at least it's good to assess for sure. So now we're going to talk about VBI, which the article addresses. Now I have some personal opinions that are based on literature about VBI. I'm definitely interested in your input as well. So just to kind of make sure everybody's on the same page, I have the definition of VBI here. So this is Vertebrobasilar insufficiency or inadequate blood flow through some parts of the circulation to the posterior part of the brain. And so since that serves the cerebellum, we can see cerebellar signs if there's issues with circulation in that area, including but not limited to ataxia, hemiplegia, really funny eye stuff, you know, difficulty speaking, difficulty swallowing, and, you know, drooping of the eye, or all kinds of other stuff. So you can see a lot of big neuroscience where you should hopefully be like, whoa, this doesn't seem good, right? So we're looking for a history of a patient who might describe something like, I had a patient like this actually. I was at an IMAX and I was looking like this, like to see what was on the screen. And I started to feel really dizzy. And the longer I was like this, the dizzier I got. And then I started to kind of feel a little faint. And then I got, you know, like I felt my wife said I looked a little droopy, you know, like kind of like, like, okay, this sounds bad. You know, and, you know, so any concurrent neurosigns in that position. So if they're describing or you observe any of things listed in this nice table box that I've listed, then that would be possible vertebrobasilar insufficiency. So what the literature says that in order of importance, we suspect VBI if they have stroke risk factors. The history I just described, it doesn't have to be an IMAX movie, but something where they were kind of maybe in that position and then we have these symptoms brought on. And if the vertebral artery test is positive, now what we know is that if the test is negative, whether you do it with them or they've had it done before, just because they've had that test does not mean they do not have VBI. This is very important. So here are the stroke risk factors in case you're not familiar with them. And what is recommended again in the literature is you want to refer for imaging if they are suffering from isolated positional vertigo or dizziness of an unexplained etiology. So you've already kind of ruled out some other stuff maybe, you know, nothing else is making sense. And they have at least 3 stroke risk factors. Because I figure, you know, we don't want to send everyone for this kind of imaging, but whether it's an MRA or a CTA, as opposed to an ultrasound, which is less sensitive, just noted. Okay, not that we're trying to give the doctors advice, but, you know, in case you see that come back instead of the CTA or the MRA, you're a little less confident that it's not VBI at that point. You know, but if I'm having kind of this combination of a history that kind of fits it and, you know, my kind of quick exam, you know, isn't showing it, and I will do Dix-Hallpike. I know people say, oh, if I even worry about VBI at all, I wouldn't do it. You're going to see pretty quick if they have a positive, you know, it's not an officially a VBI test, but if they're in the Dix-Hallpike and they start to show any neurosigns or anything, you just get them out and you stop there, pause, all right, you're going, I'm calling your doctor, I'm concerned about, you know, possible, you know, vascular issue here. So, you know, if we do the vertebral artery test, which you can do in sitting or supine, again, here's how it's done if you choose to do it. And some people choose to do it for liability reasons. And that's something that can be debated. But the reality is that the sensitivity is 0%. So that's not great. The specificity in different studies completely varies from very low to high. So, you know, if you get a positive, I'm concerned. If you get a negative, I don't know that you don't have VBI. So that's kind of my 2 cents. Do you have anything to add or something different? I'm interested.
Oh, we could talk about this for days, but I don't want to take up too much time. But yeah, I mean, we basically agree. And really, the concept we go after is several different strategies which we talk about, but one of them is this is more of a positional versus symptoms versus positioning. So like BPPV is positioning, cervicogenic dizziness, looking up, maybe rotation. It's going to be positioning, where positional would be kind of your example in the IMAX, okay? Because you're looking at 4 ports of blood flow going north, and it's just basically one of the other ones can't compensate for a lack of blood flow, right? And so, so the first thing is the history and stuff tells you a lot about that. The second part is the probability of someone having a mechanical disruption from a vertebral artery disturbance is low. It varies in numbers, and so the main point of the concept now is that we want to make sure we rule out what we call a spontaneous dissection. Someone's coming in with vertiginous symptoms, a lightheadedness, whatever the concept could be based off of these signs and symptoms. And we just want to make sure they're not coming into your office with a stroke. Okay. And that's really the main concept. And then, and that's what we done. That's what our paper has been on with our mentor, Brett Harper. And then you basically can move if you feel like nothing's matching up and things aren't matching up, then you can move into kind of a mechanical assessment, which could be the vertebral artery test. That could be further way down the line in the sequence of events if you're really, really concerned and nothing has helped whatsoever. And you could do that, or you can refer out. But that would be where I feel like this test is still useful to an extent, but it's not sensitive. So you don't do that first in your exam because it doesn't rule anything out, but it is a little bit more specific. So if you're concerned, you move it down the chain, and then you're thinking, all right, some sort of osteophyte or some sort of anomaly or something is causing that disruption there that might need, obviously, medical intervention versus something physical therapists use, right?
Good. I like it. All right, on to cervical distractions. So this was not covered in the article, but we mentioned it in one of our social media posts because we were very intrigued by a really beautiful page that you have that describes whether or not we should do the cervical distraction test in people with potential cervicogenic dizziness on your cervicaldizziness.com website. So essentially what they what you talked about, and I know you looked at the literature, so I admit I didn't look at a lot else. Freely admit that. Is essentially if you do distraction and it relieves symptoms, whether it's your traditional radicular symptoms, looking at kind of more of an orthopedic concern versus the cervicogenic dizziness, where it relieves their dizziness. That's something to note. I do something and that takes away your symptoms. Okay, what did I do? What was I affecting? Oh, I was affecting the neck when I distracted, and that took away your dizziness. That's interesting, right? Because if I have BPPV, that's not going to happen. I can tell you, So it's not going to change how they feel. So that's just something to kind of attend to, I would say. So coming back to this graph, I think, or this kind of chart, we've kind of covered what was presented in it. So we're finished covering the article except for treatment. So I know you guys are going to have a lot to add in this area, so I'm just going to kind of really briefly cover things that were suggested. So training the deep neck flexors if they're found to be weak or having poor endurance or whatnot, we treat that, right? This is hopefully A and B. This is what I like to see. Okay, I found these problems. Let me try to treat those problems with the appropriate treatments that match up. So cervical joint positioning training, also very fun to do, getting that laser out a lot. And they can trace, you can use the target, which I sometimes do because people sometimes kind of jive with that initially anyway. So I don't always treat to the test, but sometimes it's a good way to kind of get people to understand it a little bit. And then you can certainly use patterns, which you guys have some lovely free ones up on your resource page, which I love. We can trace letters on the wall, which could be on a paper that you print out, or you can put them up on your wall with paper tape, which I have done in my office. People always ask me, what's that for? It's kind of a good little talking point. And then, of course, you can progress this kind of activity in so many ways, whether that be with changing the speed, adding a balance challenge, so having them stand on a foam pad or a BOSU or whatever, having them in dual tasks, so they have to trace and catch a ball or spell words. These are my concussion people, kind of maybe my higher level, quote unquote, physical folks that need more challenge. They're going back to maybe a high level sport. Maybe they have to move while they're tracing, marching in place, walking, turning, you name it. So I'm sure you guys would have even more to list off. I just kind of did stuff off the top of my head there. And then manual therapy, which we know we have some experts here on that. And so we'll talk a little more about what you might specifically recommend. But this was described in the article, or kind of we talked about doing distraction and if that relieved the dizziness. And there was a specific quote out that quite a few of the neck proprioceptors are up in our upper cervical spine, which is why we might specifically kind of focus some of our treatments on those if they're found to need mobilization, according to our manual assessment and things like that. So the take-home message to me from this whole article is, when you have a patient coming in with dizziness, think about that the neck may be a layer to the onion. Maybe it's the whole shebang from, causing all of these kind of off symptoms or whatnot, or maybe it's just one piece. And so it should be assessed and treated if we find something that needs that. And this is my argument to the doctors. If they're like, cervicogenic dizziness, it's totally made up. I'm like, well, you know what? Even if the neck isn't making them dizzy or imbalanced directly, I need to address any cervical pain and make sure that they have adequate movement and strength and posture and things like that, because most of my vestibular exercises and balance activities rely on some neck movement. So, even if we just want to go that route, I think it's appropriate. So however you slice it, the neck is important in my book. So I think we're ready to transition to our live chat. So let's do that. Oh, we got some questions already. Who's excited?
Oh, wow.
So let's see if we can catch a few of these. One of the questions is, if a patient is symptomatic with vertebrobasilar insufficiency but has no neurosigns, what would you do?
So when you're thinking of someone getting neurological, I'm assuming maybe nystagmus might be what they're asking, or maybe the neurosigns from the get-go of drop attacks and things. So sometimes neurosigns won't come until there's been a long standing disruption in blood flow. So like they may be coming into you with a spontaneous event and you don't have any neuroscience. Your cranial nerve exam is normal, right? But then you aggravate the cardiovascular system, and then you get symptoms. So I'm not real sure exactly what that means, other than in a small percentage of cases that they may not develop anything neurologically, but it's the spontaneous dissection that is bringing them into the office. So they wouldn't have neurological signs at that point, unless you did something to create neurological signs, such as work on their neck or put them in a maneuver or something like that. That's not appropriate for them.
Got it.
And I think typically people are going to come in with dizziness, right? That's one of their chief complaints. And if you put them into that provoking position, and I think this is what the question is. I mean, if they have dizziness into that position, that certainly doesn't mean red light, because there's a lot of other things that could be provoking, whether it's from the neck, whether it's even, BPPV, a lot of other scenarios. So you, like Harrison mentioned, you would definitely dig into that a little bit more before having that concern, because of course dizziness is part of the 5Ds.
For sure. Yeah, so we jump to concern for VBI if they have neurosigns. If they don't have neurosigns, but it fits some of the history, we just kind of look at our other exam to say, is there anything else that really explains this? And if not, and especially if they have some of those kind of stroke risk factors and things like that, then we might point back to imaging to rule out, even though they didn't have the neurosigns. That's kind of my two pieces on that, I think. So great question from Lisa. We also have a question. I've heard in the past that the vertebral basilar insufficiency test should be called the cervical artery insufficiency test, as it may test the carotid artery as well. What are your thoughts on that?
Yeah, Jeffrey, you're right. I mean, I think the author of this article we're talking about, Song, it's a little maybe behind of what even an international framework for orthopedic manual therapists is calling for now. Even Rogers Carey work, that kind of even goes back to 2014 and 2017. So yes, the BBI is a concept, a component underneath the entire cervical stasis concept. So you can't just forget the internal carotid is the main concept here, which is going to be perturbed in more extension than it is rotation. So you're absolutely right. So in the article, it's just a small subset BBI, but it really should be a much complex system, which is kind of brings part a much deeper understanding of ruling out spontaneous versus mechanical stuff.
For sure. And I think that the vertebral artery, basilar artery gets a lot of press. So I think it's just kind of been talked about more. And, it's interesting to think of like what a cardiologist perspective would be versus, say, like an ENT as far as what the language is and how to focus that. But ultimately, we do look for, is it vascular? That's a concern. Wherever the problem is. Right.
Yeah, exactly, and because most things might occur right at the internal external junction down lower in the cervical spine, more C5 C6. So I think the VBI came about in the early 1926. The client talked about it to basically because the case reports started in the I think even in the late 70s, the early 80s and 90s of manipulation causing a stroke, and that's really what stemmed the VBI based off of the rotation as it goes into the zone 3 around C1, and so now we're just knowing it's a much bigger complex than that. So that is a little small history of it, but
yes, very good. All right, next question. We're talking about joint position error testing. There's an article that talks about doing 10 trials in each direction, and Jeff is saying he does 3 based on what he's read. And I know you kind of mentioned, Danielle, you're doing probably 3 to 6. Does that sound about right?
Yes, that's pretty much. I think more the standardization is 6, but yeah, I wouldn't say I normally go even that. It just is a time intensive thing. So 3 generally is about where I am.
Got it. I feel like there's very few people that by 6, it's not pretty clear whether there's some sort of pattern for each of the directions. So 10 probably feels like a lot of time.
Right. Well, and it's motor learning, right? I mean, if you're doing it over and over again to the same target without really changing much variable, at least within the head rotation, body rotation, or other things, then you're doing exactly what you want to do with your treatment. You're retraining on what that answer is, on what that proprioception should be. So if you're going to be doing 10, I would imagine that's going to skew in the end after reaching a certain amount of reps. Anyways.
Got it. All right. Well, Ben's asking us, that's a good point, Danielle. Ben's asking us if you're doing the vertebral-basilar insufficiency test, does it make a difference if you do rotate or extend first?
Yeah, good question, Ben. So I would say if you're majorly concerned with this, you probably shouldn't even do it. That's what most of the major office going to do it. But we talk about a 3-step process that you can bring them into rotation and hold them there. And if they're fine, you go back to neutral. Then you can bring them into a full extension off the edge of the plinth. And if they're fine, then those symptoms, you can bring them back to neutral. And then you could do the combined rotation extension. So it's a loaded answer, Ben, but typically rotation is going to perturb the vertebrobasilar, all right, because of zone 3 there, versus extension is going to be mostly internal carotid, but it sort of kinks it. So, but I would do it in those phases technically, but there's no research to show if you have to do one or the other, really.
Got it. All right, I'm going to jump to Pretty's question next. I am seeing a few clients post neck manip dizziness and BPPV. What would cause this? Is it the neck position or the thrust applied or some sort of vertebral artery strain? What do we think why would someone kind of end up with BPPV that seems to be potentially related to right after they got some sort of neck manual manipulation?
I would say it's probably not BPV. They might not be appropriate for that manipulation. It's a small percentage of individuals. It might not be appropriate for that person based off of their collagen or like Ehlers-Danlos or something of that nature. And then this opens. So I would say that it is considered a trauma, a mild trauma with the manipulation. Almost that would be a subjective finding that you might ask about, because that could be a red flag for some other things, of course. But so I would look at it that way. That's probably not PPV. If that's the case, it probably is some sort of mild trauma. And then that opens up next camp if you should manipulate people with dizziness or they're and turn their head 126 degrees per second, or should you do other procedures? So, to answer your question, Danielle might have a better answer for BPV, but I would say they're probably not getting PPV from it. It's probably just.
Yeah, I'm not sure if I'm understanding the question directly. If you're saying that you are definitely seeing a confirmed BPV afterwards, and in that case, then I would kind of wonder how they're manipulating their patients, because that's pretty concerning. Like with what Harrison said, I mean, it should be it's not a whole lot of range supposed to be going on there. So, although I wouldn't say it's, I guess it's possible, but yeah, I would think it's probably more related to the manual aspect of what you're saying.
I think what's tricky is causation and correlation. So what if someone comes in to see someone who's maybe a manual focused person, and they say, I have dizziness, and the person says, oh, I'll do some manual on your neck to help. They might just have BPV the whole time and it just wasn't checked for BPPV, right? So that seems like one possibility. And the second one, although less likely, is to say, someone's lying in a certain position, maybe they happen to have PPV happen at that time, or after they had the manipulation, they were laying a certain way. And the problem is BPV is so common and spontaneous in nature that, to tie it to events like that, it's not to say it couldn't happen, but it's hard also to say that it was definitely tied or not. I think I've got that right. Yeah. All right. So Amy's asking, how many errors are necessary to consider a positive joint position error test?
They don't have particularly, again, because I just kind of do my own modification of the 3. So things that just kind of stand out, typically if it is actually like an obvious difference, you have maybe to the right, you get 0, 1 out of 3 versus the other side, everything else is 3 out of 3. I mean, it's kind of vague with that.
Yeah. What I learned. Go ahead. Sorry. Yeah, I think I am with you. I think it's more of a pattern. So yeah, if you get one wrong, especially the first one when they're just figuring it out, and then the rest they're nailing, 2 or 3 more correct or kind of normal, then I don't worry. If it's more on the 3 to 2 to 3 at least wrong out of say 4, that kind of thing. Now I'm thinking, okay, that seems more abnormal. Does that seem right?
Yeah, I use it. Yes, exactly. I mean, it's kind of, and one thing that's interesting in this article that they don't mention, and now that we're on the questions, I guess we will, now it's time to talk about it. Cervical when you look at cervical torsion test, where you basically are sitting on a stool and you're keeping your head in the same position and you're rotating the body and you're looking in 4 different positions and you're checking for symptoms or nystagmus, which is more of a clinical test. That's really like our biggest cervicogenic dizziness specific test. And if you're looking at, is this actually potentially coming from the neck, versus I look at joint position error as, should we train this? Should we incorporate this in our treatment? Not necessarily like, is this coming from the neck, if that makes sense.
Right. And I think that's a good point. I think the article was nice in a way because it tried to cover it succinctly, but then of course whenever you try to keep things tight, you lose things. So the fact that they didn't mention that test, I agree, is good.
I mean, it's a huge topic. I mean, we talk about it for 2 days. Our first full day is all our algorithm on ruling out and getting to the exclusion, and the whole second day is treatment. So it's a ton of stuff to cover, which is why I said, I mean, going into that second day and continuing your exam is, I don't know how you would not do that, to be honest.
Right. So I think this is a separate question, just kind of coming back to that vertebral-basilar insufficiency test. For how long you should hold it? Is it 10 seconds, or is it not enough to get signs, do you think?
This just spells to how bad the test is, to be honest. I mean, 10 seconds, technically, 55 seconds is going to be latency or so for something in the something cerebral kind of going on. So 10 seconds is, yes, generally what's described. And that's just not going to give you the answers. But that just shows why the test is really not that great. So hopefully that answers your question. But normally it's described anywhere from 10 to 30 seconds. And we have a ton of literature that's just described through that. That's kind of the time frame. Yeah.
Got it. All right,
you hold anybody back with their head for a minute and some change, and something's not feel right. Especially if you keep asking them, how are you feeling? Keep your eyes open. It's just not that great.
Like, I don't want to be in this position anymore.
Right. Please get me up. If I tell you I'm dizzy, will you take me out? Yeah.
Totally. All right. So I got some more questions from Jeff here. I'm going to try to see if I can hit all these questions. This is awesome. So this is kind of more of a comment. Could you recommend having the person seated, leaning forward, and then rotate and extend their head as a way to test, I believe, the vertebrobasilar artery? So that's kind of that seated, right, as opposed to...
And that's definitely preferred, especially if you're kind of thinking BPPV is maybe a possibility, because of course you're thinking about the relationship with gravity and the crystals, right? So that modified position takes out that extension against that plane. So that's actually a big point, a really important one too. So I'm glad you brought that up because we didn't get a chance to.
Yeah, and it's one study that talks about it, and I'm drawing a blank on the author's name right now, but that's pretty much how the algorithm talks about it. Because if you're going to bring somebody and get them down, you're already thinking, let me do Dick's Hall Pike, like at this point. So and then you're just going to go into the Epley kind of concept. So that would be the order of operations you would want. So the seated one is good. Yes. It's just not studied as much. It's only one study on it.
For sure. So the second part of Jeff's question, if I can interpret this correctly, would you put them in supine to test the carotid artery? In addition, it looks like, not just testing the vertebral artery with the lean forward position.
Yeah, say that again. I'm sorry.
Would you test the carotid artery by just leaning them into what I would call a deep head hang, but like that sort of position, or is that not necessarily helpful?
For just the internal carotid,
Mm-hmm.
Technically it would. Extension does perturb it. It's never been. We would break it down into rotation first on the plinth, and if that's clear, then you could go into extension. It could be a 3-step process if you're really concerned. So that, yes, you could. That would be the second part of a 3-part series of how you could do the VBI test. That's described a little bit different than this author. Is that utilized in the clinic? Typically not.
Got it. Okay. Lisa had asked, I have a few patients that seem to test positive for vertebrobasilar insufficiency, but then follow up with their doctors and they're all clear. Can you clarify how you would test and other things to consider? So you thought maybe it was VBI, and it turns out, maybe their MRA, which hopefully is a gold standard, is negative. Where would you go next?
Well, that's a false positive.
Yeah, is that just are you thinking just with the objective test and doing that test? I mean, the history is a huge part, as you mentioned before. I mean, that's really much bigger than our test. And so considering like you mentioned before, like the risk factors with stroke and their history with smoking and cardiovascular disease, all those kind of things are really the bulk of what you want to look at if you have those concerns. And then of course matching that up with the objective if you can. But
yeah, and although I realize that no test, including an MRA, is foolproof, I feel like if it comes back clean, that certainly makes me more confident that,
Yeah.
if you ever have a very minor vascular component, but there's other things that I can address. And so, again, I think that brings us back to the neck in general. And, again, making sure all my vestibular tests look clean, no sneaky BPPV that's coming and going or something else that maybe kind of could mimic in some ways.
sure.
Some
And
of
there's
the
so many
presentation.
modifications. So many modifications and things that you can do if you are considering BPV, different maneuvers that take less rotation or extension of the neck, with your treatment strategies, maybe keeping it in smaller ranges if you really are concerned, and treating them, doing something, right? There's still something that you can do to help provide better quality of life.
Got it. Yep, and it looks like we have another person who's agreeing with you too about kind of sitting slouched and doing neck rotation to test the vertebral arteries. So that's good. We're all on the same page there. Let's see. I think I might have missed a question here. There's so many. It's kind of hard for me to make sure I don't miss any. We got 4 minutes left. I'll have my technical team just kind of scroll through one more time and see if there's any that maybe got pushed up that I didn't see. And while he's doing that, I have like 10 questions and I'm only going to ask 1 or 2. So let's see. So this is probably a tricky question, but what are the top 3 manual therapy techniques that you typically find the most helpful on a consistent basis? If you're pretty sure they have cervicogenic dizziness, what do you feel like comes up again and again as being kind of the hot ones to use?
You want me to answer? Yeah. Well, I mean, I think to simply answer that, you have to treat the upper cervical spine, right? So a lot of the upper cervical spine mobilizations, some soft tissue work, or however you want to do suboccipital release, you have to get the suboccipitals, to get the deep neck flexors, just definitely the upper cervical spine, and however you might want to, like we say, like whatever juice you're drinking on, if you want to needle it, if you want to mobilize it, if you want to do soft tissue release, anything, cupping, like there's a lot of different ways, but you have to address that upper cervical spine. And then some of the stabilization, I mean, we talk a lot about that in our course as well too, and retraining.
Snag.
Yeah. Oh yeah. Thank you. Yes. And the snag is another big one. C2 snag. There's a lot of research to support it, and we definitely see that clinically as well. I mean, it provides a great window of opportunity into any of your vestibular rehab that you're going to do afterwards. So I know I typically start with more of the manual type things to help them optimize whatever we're going to do for our vestibular program as well.
Got it. We have a good question here. Any favorite cervical stabilization exercises?
Hey, good question, Amy. So one thing we like to do as well is we already talked about the deep cervical flexors, but sometimes we can do the deep cervical extensors too. And it's a lot of stuff coming from that. So a lot of times quadruped it's a good way to work kind of both at the same time. So basically you can get them quadruped with some chin retraction works and holds. You can even do some sensorimotor training with tracing and stuff down in that position. So that, I'm sure you probably are doing that, but we like that. We created that we like to basically push their head into a ball to stabilize. That's one that is one of my favorites. I tell them I'm going to squish their head in a ball and they have to hold it, which is fun for both parties. So those are my 2 favorites.
I think the point with that too, because that is actually a very interesting but very effective exercise, because you're trying to get them to activate the right muscles, right, and not getting those SCMs and scalenes, and even if you're doing your deep cervical flexor test, and a lot of them are going to feel it activating significantly more into those extensors or their upper cervical extensors. So trying to normalize what's activating and what's overactivating as well is really important. So the ball one is kind of neat, where basically you have the ball right under their head and you're pushing their head back, and then you ask them to hold it there, and then you slowly bring your hand out, and it really helps them find those muscles and to target those muscles. And then of course loading from there is super important. So you get them to learn to know how to activate those muscles. And some of my favorites, just general exercises I do once they get that, is I try to get them up and standing, and I do like the Y band exercise, but I have them retract a little bit. So they're activating mostly, you know, rotator cuff, scapular muscles, but making sure that they're also feeling that into this area. I'll do some TRX stuff as well too. Other band work, you know, horizontal abduction. It doesn't really matter what you're doing, but as long as they're feeling those muscles to activate in more of a loaded position, standing position, and with some kind of extremity weight as well.
Mm-hmm. And you're talking about like what size ball are you putting in there?
So we have like a Pilates ball, and it's really deflated, and you put it under. Am I in there? Yeah. You put it under here, and then they like tuck, and then you push them down. So Harrison made up this exercise, and I've kind of stolen it and use it quite often.
But so the ball is behind the head, but it's not. The ball is not here. They're not trying to crush the ball.
No. Yeah.
Okay, good, because I keep seeing the hand going here, and I'm like, I don't think that's what they're saying.
Yeah.
Yeah, so it's a co-stabilization for flexors, extensors, and then you're doing retraction. So we know that with some of McKinsey's literature, just doing repeated retraction activates the longest calves, because we're not in this position. You know, that's just a lead tension relationship. So it's kind of all in one.
Got it. I like retraction and what I call the farmer's carry. Concurrently, because that's super functional. You're carrying the groceries. All right. Yeah. Anyway, so we are at time and a little past actually. So that was awesome conversation, and I know we could again talk much longer about this topic. But if you are looking for more, I'm actually gonna swap slides here and take us back one notch to. Messed that up a little bit, but I promise I will fix it. So we're going to go to this slide, which is about Harrison and Danielle and what else they have to offer for you. So if you're like hungry for more at this point, because this is a huge topic, there are books that they have written that would really be helpful to you, I think. So you can check those out. And there are also courses that they teach, as they've mentioned a few times. So there's a live course coming up in South Carolina, or you could, I would recommend, book a class for your staff, or maybe you can get a few small clinics to band together in your area to benefit from their knowledge. So if you're interested in that, you can email them at cervicaldizziness@gmail.com. And of course, check out their website, cervicaldizziness.com, for all your cervicogenic dizziness needs. A lot of resources and some, like I said, those free patterns to trace and things. You guys can access that too. So thank you so much for taking the time, Danielle and Harrison, to talk about this like huge topic. And we really appreciate it.
Yes. Thank you.
Thanks for having us.
All right. Thanks, everybody. We'll see you next month in September. We'll announce the topic very soon. It's going to be exciting.
Bye.
Bye.
Okay.